Hi everyone, today we are going to talk about an important and my favorite topic, cornea. I am Dr. Syed Musa, I am an ophthalmologist. So coming to anatomy of cornea, cornea is a transparent outermost coat which covers the anterior one third of the eyeball. This is what is cornea. So what are the important points about cornea is that it provides 2/3 of refraction. So the refractive power is 43 to 44 diopters and the total power of the dioptric power of the eye is 60 diopters. So the refractive index is 1.376, which you should remember, and the thickness, central corneal thickness and peripheral corneal thickness. Central corneal thickness is approximately 520 as an average is the normal central corneal thickness, whereas the peripheral corneal thickness is 700 to 900 microns. Basically the center is thin whereas the periphery is thick. That is how we are able to refract an object. And one more important point about central corneal thickness is that the central corneal thickness helps us to evaluate the pressure inside the eye. Also during LASIK procedure, it's very useful in order to measure the central corneal thickness, because we basically cut the cornea or thin out the cornea either in the periphery or on the center in order to have better refraction in a patient. So that's why we need to know the central corneal thickness, which is of very much importance in practice. Coming to the anterior surface of the cornea, it's elliptical. Vertical diameter is 11.7 mm, whereas horizontal diameter is 11 mm, and the posterior surface is circular, which is 11.7 mm. So coming to the microcornea. Microcornea, if the cornea's diameter is less than 10 mm, it's called microcornea, whereas the megalocornea, corneal diameter more than 13 mm, it's called megalocornea. The radius of curvature, anterior surface is 7.84, whereas the posterior surface is 6.4. All these tiny information, if you can remember, it's well and good. If you can't, it's fine. But the most important thing is the central corneal thickness, the refractive index and the refractive power of the cornea. All these things are very important. And what is microcornea, megalocornea, all these things are important. The points which are highlighted in the red ink, those are very important for your entrance exam. Coming to the layers of cornea, from front to the back, it is divided into 5 layers conventionally. One is epithelium, Bowman's membrane, stroma, Descemet's membrane, endothelium. Okay. During my entrance exam preparation, there was a mnemonic A, B, C, D, E. That's just an alphabets. So A stands for anterior epithelium, B stands for Bowman's layer, C stands for corneal stroma, D stands for Descemet's membrane, E stands for endothelium. But now there is another layer called Dua's layer by our own Indian ophthalmologist Harminder Singh Dua sir. So he made this layer called Dua's layer. That's called that's a pre-Descemet's layer that is between stroma and the Descemet's membrane. I'll show you all these points here. So it's composed of 5 layers from external to internal. They are epithelium. Stratified squamous non-catenarized epithelium. This they have asked several times in your entrance exam. It can regenerate. Epithelium can regenerate. That's one important point. If the epithelium is peeled off, as in the case of epithelial defect or any erosions, it can completely form again. That's the reason in certain LASIK conditions where we remove the epithelium in order to ablate the cornea, but in those conditions the epithelium can regenerate and no harm in that. But Bowman's layer, that is the second layer, if it gets damaged, that's when it leads to scar. You have seen some corneal ulcer or epithelial defect patients and all, there will be a scar because of this involvement of Bowman's layer. Anything after the Bowman's layer involvement, it will produce a scar. Stroma, as you all know, it's the thickest layer. The corneal lamella is all arranged properly. That's the reason we are able to see clearly. And coming to the last fourth layer, that's the Descemet's layer. It's the toughest layer. Only fungus can penetrate intact Descemet's membrane. I will describe about all these fungal corneal ulcer and all, why it's called, why it is immobile and why it is a non-sterile ulcer, because the fungus can penetrate Descemet's membrane, whereas the other organism cannot enter Descemet's membrane. And organisms that can enter epithelium, I've described that in your corneal ulcer topic. Those are Neisseria gonorrhoeae, Haemophilus influenza, and Corynebacterium diphtheria, Neisseria gonorrhoeae and Neisseria meningitis, and also Listeria. All these organisms can enter epithelium, whereas coming to the Descemet's membrane, only fungus can enter intact Descemet's membrane. If it's broken, anybody can enter, but if it's not broken, then only fungus can enter. And then the next layer is endothelium. It's very important as a most metabolically active layer. It is composed of single layer of hexagonal cells. Damage leads to corneal edema. The endothelium acts as a pump in order to push the aqueous out of the cornea. If it gets damaged, if the cells are the normal cells are 3000 cells per cubic mm, if it's less than that, if it's less than 500, that's when you will get all these corneal edema. So 3000 is ideal, but if it's less than 500, then you cannot use the endothelium, whereas 2000 is an ideal condition where we can give it for transplant in the case of keratoplasty. So endothelium, it's very important as a metabolically active layer. And the sixth layer is Dua's layer. It's recently identified by Harminder Singh Dua sir. It lies between stroma and Descemet's membrane. That's why it's called pre-Descemet's membrane. So coming to maintenance of corneal transparency, the factors responsible for the maintenance of corneal transparency are many are there. The most important is that smooth texture of the epithelium. If there is any epithelial defect or tear film defect, then you cannot see properly. Arrangement of the stromal lamellae. The regular arrangement of the stromal lamellae ensure that all the scattered light is lost by mutual interference. And avascularity, that is very important. Cornea is avascular. That's the reason we can do penetrating keratoplasty. So avascularity, unmyelinated nerve fibers. That's the reason the cornea is very sensitive, and any small hair or any small foreign body that touches the cornea, it will lead to a lot of irritation. So cornea, two important points: it's non-vascular, avascular, and it has nerve fibers. So these two things are very important. And arrangement of stroma lamellae is the main key feature for your corneal transparency. And also endothelial. Next is the endothelial pump mechanism. The endothelial pump, sodium potassium ATPase pump, ensures an optimum level of corneal hydration by pumping out excess water out from the cornea. It's like how we use in our house the pump and all. That's how we retrieve or to send the water from one side to the other side. This relative dehydration is responsible for transparency. That's very important. So optimum hydration of cornea is 80%. So any damage, let's say in the case of pseudophakic bullous keratopathy, if there is any damage of the corneal endothelium by an inexperienced surgeon or surgeon who is learning, what happens is the endothelium gets damaged, and because the endothelium gets damaged, all the water goes and accumulates in the cornea, leading to pseudophakic bulle will be formed, bullous keratopathy. So the next thing is intraocular pressure. Increase in intraocular pressure affects the endothelial pump activity, leads to increased hydration of cornea. As you would have all known, acute angle closure glaucoma, you would have seen corneal edema and vertically oval pupil, all those things. The corneal edema is basically due to the endothelial pump gets damaged because of the high pressure, and that's the reason the water gets accumulated in the cornea. Coming to the important investigations related to cornea, pachymetry to measure corneal thickness. So coming to pachymetry, I told you two reasons. One is that if let's say in the case of glaucoma, the second is the refractive correction, like refractive surgeries. So in the case of glaucoma, the more the thickness, I told you 520 is a normal thickness, 520 microns is the normal thickness. If the thickness is more, okay, then the chances are that the reading is overestimated. When the thickness is less, then the chances are that the reading is underestimated. Let's say for example, this water bottle, if the thickness is more, the pressure will be overly estimated. But let's say in a balloon, the pressure inside the balloon, that will be less compared to this, even though if the pressures are more, I mean if the pressures are same, the balloon, and if this bottle you measure, the pressure of this bottle also influences the actual pressure of the water. So that's the reason we check the pachymetry and check the corneal thickness. If it is more, then we have to correct it by minusing the power. We have a correction factor, we minus that. If the thickness is less, then we have to add the correction factor. So that's about pachymetry. And as you see in this first picture, that is what is pachymetry. You will just touch the cornea and you can say the central corneal thickness. It's the central corneal thickness, not the peripheral corneal thickness. Remember that. And how I remembered is, instead of pachymetry, I wrote it as patchymetry. So the T reminds me of thickness. And keratometer to measure corneal curvature. The second one is the plastose disc. Based on the rings, how concentric the rings are, you can see the curvature of the cornea. So that is what is keratometry. So how I remembered corneal curvature and keratometry is that I imagined like writing KSC 1 and C and keratometry. So C reminds me of corneal curvature when I was preparing for entrance exam. So those mnemonics right now it doesn't help me, but those times it was very useful. And corneal topography measures corneal curvature, shape and thickness. All those things can be measured in corneal topography. Then comes the specular microscopy to assess the corneal endothelium. I told you the count should be more than 3000. I mean, normal is 3000. It should be more than 2000 for you to give a transplant it to a normal patient, and it should at least be more than 500. That's the minimum that should be there. Otherwise, there will be edema. So this is how so specular microscopy shows in this picture given here. The first one is the normal one, and the second one is all these things are gutties. So there is the endothelium is damaged. And the next is anterior segment ocular coherence tomography ASOCT to assess different corneal layers. These are hi-fi stuff for you, corneal topography and ASOCT, all these things. Vital stains, this is very important. Fluorescent stain to identify epithelial defect. Basically what we do is like we stain the patient's cornea with fluorescein, and then we show it through a cobalt blue light. So what it shows is the epithelial defect. Whereas a rose Bengal stain, it stains the degenerated epithelial cells. It causes a severe stinging sensation, so hence rarely used, and it doesn't stain as easily as fluorescent stain. So that is about vital stains.